Azretia mae bedazo Balezwa mae bedazo Anyazwa mae bedazo Be mae zizo blazo Blazo Mamia kisi minya ule muktakolo Kiswa zwali ya yefe Mami kesi familia koni oni tolo Kiswa zwali ya yefe Balongo longo 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 mao mao Balongo longo 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 mao mao Balongo longo 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 mao mao Balongo balongo longo longo mao mao Tifezwa maebedazo Anyatia maebedazo Brahma kota maebedazo Petit Paris a maebedazo Be mae zizo blazo Oh vieux briscard La nuit tous les chats sont pris, ambiance sapée. Et voilà lélé, tu es magadi, magadi, Eja kwamie Eja mia Eja teba emo Eja closia emo Eja esa emo Emo akuba emo Vis-à-vis complet Et où les vis-à-vis complet Vis-à-vis complet Et où les vis-à-vis complet Nieblo timizula mame Nieblo timizula mame Nieblo timizula mame Nieblo timizula mame Eli ulia mandrozule Eli ulia mandrozule Ezi ulia mandrozule Ezi ulia mandrozule Eli mukalenga Alenga 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 Alenga
Yeah. Do a 16 page, that's fine. That way you can save, you know what I mean?
So what we're going to start with self-introduction. Boyka is my name. I'm the coordinator for Southwest Social and Community Support at the Ministry of Health and Social Welfare. And we've been working with Dr. Simmons to make sure that some of her knowledge is left behind when she leaves. So we had a discussion, we go back on, and we decided to have a half day and a workshop on cognitive behavioral therapy. So, ladies and gentlemen, Bagon will officially open the workshop, but that's Jordan. So
Yes, we're in hospital. That's usually how I run my workshop. So when you say your name, could you just say, what you do and also an interesting fact about yourself, just so we can get to know each other?
BSc Nurse ESN. I work on the ward taking care of mentally ill patients, and I also treat patients.
All right. All right.
My name is William Obanto Kane, a registered nurse, work at ES Grant. I'm a mental health clinician and I'm a screener. I'm single with few kids, but not online.
I'm Mariette King Kanga. I'm a BSc nurse. I work at the Grace Hospital. I'm married with 3 children, and I'm a very sociable person.
I'm Jeffrey W. Yike. I'm a registered nurse, mental health clinician, work as one of the screeners here in mental health hospital. I'm married with 4 children.
Yes, nurse at PS Grant. I love to talk to the patients.
Okay.
I talk to patients, conduct session with them. I'm a married guy with 2 lovely boys. And mainly I love sport, football, volleyball.
I'm Reverend J. Lauren Douglason. I work here as a social worker. Outside that, I'm a pastor. And I'm married with 6 children.
I'm Prince A. Davis, a bachelor degree social worker. I'm single and I love sports. And also social worker. I'm a social worker here. We identify some of the psychosocial issues that patients have. Also, we conduct psychoeducation for them and so on.
I'm John Yapaulo. I work here as an occupational therapist. This is my 11th year in the field of mental health program. We conduct sessions for patients, and also we meet with family members in addressing some personal problems that were developed as a result of frustration. And we also provide favorite therapeutic activities for our patients. I love reading.
Marian F. Lugo, PhD in Cotton University. I work at ES Grant. I work on both female and male wards. And sometimes I do screening in the screening room. I was married, but I'm now a widow with 5 living children, 2 girls and 3 boys.
I'm Baton Dua. I'm the nursing and clinical supervisor at ES Grant here. I work here for 7 years now. And I'm also a registered nurse with a BSc, trained as a psychiatric nurse also. And my work here is to supervise the nurses and also liaise with other departments like the counselors and the PAs and other clinicians. Yeah.
But I prefer to be called Kim. I'm single with 3 children. I have a bachelor's of science in biology. I also have a bachelor's of arts in Spanish. I'm going to med school to be a doctor, pediatrician, and open a clinic in an African country. I haven't decided which one yet. And I currently work as an IT operations assistant. If you don't know what IT is, it's information technology services.
My name is Alice Howard. I'm a registered nurse. I have a bachelor of science in nursing, and I've been working for God knows how many years. If I say that, you know my age, so I can tell you. I had 2 kids. My daughter is 22, going to be 23. I have a son 18, going to be 19, going to start school early. And I love doing nursing and I work in every field. I've done everything, critical care, psych. When I graduated from school, that's what I did. I did psych, working in a psych hospital for 2 years. Then I decided to go to, the clinical part, which, I learned a lot from doing that. Because when I'm doing psych, I'm not kind of like practicing my fully nursing, to expand my horizon. So it was nice when the trip came about to come to Liberia. I decided to come to help my people. So I'm thankful I'm here today.
My name is Dr. William Etta Simmons. I am a clinical psychologist. I have my doctorate in psychology and a master's in business administration with a focus in healthcare management. I currently work at Temple University Hospital, Episcopal campus in the U.S., in Pennsylvania, and I run basically a pilot program that's sponsored by the state of Pennsylvania and the city of Philadelphia, doing cognitive behavioral therapy with patients with schizophrenia. I lead a multidisciplinary team there, including a psychiatrist, multiple nurses, a lot of psychologists. Well, I'm the only psychologist, a lot of social workers. And the idea basically is to introduce CBT to that particular population, because we know we've done it with anxiety, we've done it with depression, we've done it with a bunch of different areas, but we haven't necessarily done an extensive work with patients with schizophrenia. So that's my thing right now. My areas of expertise include mood disorders and psychosis as well, which includes schizophrenia. I also am trained as an ecosystemic structural family therapist. Big term for just family therapists that look at things from a global scale. What else? I've been doing mental health for about 10 years. Everyone tells me I look like a child, but I have been doing mental health for 10 years. And I absolutely love it and enjoy it. And so I am honored to be here, and thank you so much for taking time out of your busy schedules. I hope it will be an interesting one. I hope you can take something from it. We have a lot of time, so I want it to be as interactive as possible. Please stop anything like that, please. On a medical mission trip, and the organization that brought us here is Federation of Mandingo Associations in the USA. And we've been here, some of us, I guess, for about 3 weeks, and we basically were able to generate about $5.2 million worth of medical equipment, and supplies, and we've given it to hospitals and clinics all over the country. We did an 8-hour ride to Tapata on that rocky road, and we survived, and so it's been really nice just to be able to come back. I'm Liberian. I've been out of years for over 18 years, so it was my first time back since. I've been in school ever since, so I love being back, and this trip meant a lot to me, and I hope I can impart something, with you guys before I leave. That's Sharif, our camera guy, so he can introduce himself. Yeah, we need to more. I love sports. That's all I do, watch, eat, sleep, live, sport, and I like animation, which is an interesting contrast. So, yeah. A discussion on schizophrenia because that's my passion right now, but, they requested depression. So, we're going to do depression, and we're going to talk about, CBT for depression. We already did the introductions. I talk fast sometimes, so please slow me down, put your hand up, say slow down, I'll do it. I'll do it. We did the first part. The second thing is, maybe 1 or 2 people, if they want to share what their biggest challenge is of working with the mental health population.
What I've experienced in working with patients with mental health issues, one has to do with when the patient is here and we try our possible best providing medications and psychotherapy for them, they get much improved and they are discharged, they go home. After some time, they experience relapse. So I see that as a big challenge, or one of the biggest challenges about patients with mental health issues. And another has to do with when patients are admitted here and they are much improved and need to go home, when they are discharged and relatives are called and they fail to come, sometimes they abandon their patients with us. So I see that as a major challenge as well.
Okay. We have a lot of challenges, but one of the main issue is most of them, they do not want to be identified because of stigma.
The lack of the alliance, therapeutic alliance. When the patient is here and happens to be discharged, in as much as the patient, the relative, and all supposed to meet and best help, we find it difficult because of lack of logistics. We don't go out to see our patients. Yeah, we never see them when they are out of here until they relapse before we can see them. We don't go there. And the relatives too don't care to tell us about these patients until we just see them. That's a big challenge.
I think that's
very unreal. So it's a big challenge for our work here.
When we are working with a patient and they improve, they go back home, sometimes they themselves find it difficult for support because they alone cannot manage by themselves. So we find it difficult. And then we from the social work department, we deem it necessary if it were possible to make follow-up. But it's difficult because of lack of logistics. Yeah. So we have to wait until maybe relapse or we have to do some telephone calls. So those things are some challenges.
Those are the challenges that even in the States we face. I have my social workers working a lot on just family support. That's a huge component, and a lot of times families don't want to be bothered, or will have a family member that maybe visit. I work in a lot of inpatient facilities, so sometimes they might visit just 1 or 2 times and not visit again. Sometimes the relapse issue is a big thing. They come back, so I can relate to some of the challenges that you guys talked about. But I do want to say this, I'm very impressed when I was talking to Bakom with the work that you guys do, especially to the best of my knowledge, this is the only mental health facility in all of Liberia. So I want to just tell you thank you for just bending over backwards and trying to help that population that no one really pays that much attention to. I think, it means a lot, and I think your work goes a long way. So thank you so much. Some people receive some training, but how much knowledge do you guys have in terms of cognitive behavioral therapy? I'll just take one comment and then we'll move on. What do you have any? Do you have exposure to it? Do you have any comments or questions about it, or Yes, sir.
Yeah, with respect to CBT. I look at it in 2 dimensions. One has to do with the thinking of the patient especially, and the behavior exhibited by that patient. For a typical example, if a patient lacks insight in his or her mental illness, they accept it as they think about it in that direction. Yeah. And as a result of that, there is a different behavior that we display. For example, for not taking medication because they feel that they are not sick. Yeah. So, because they have their mind, they are thinking that they are not sick, they lack that insight, so they behave in such a way that there's no need to take medications. Yeah.
I think we have 2 other people to consider me. Okay.
A physician assistant and also a mental health clinician. Okay. When we talk about cognitive behavior therapy, you as a therapist, you try to work with the patient on their cognition and their behavior. You try to move them from the negative behavior, and you try to replace it with a positive behavior and thinking.
Yep, absolutely. Let's share.
Yes, I'm Benetta Kama, physician assistant and a mental health clinician. When we're talking about CBT, we're talking about behavior. All is not about medication. You give the medication, and then the main thing is to change the person's behavior. What caused the illness, if you can have them to be changed, but it takes time. You have to talk, and you have to even make them to see reason for changing. So changing the behavior is the main thing for their illness.
Thank you. Lots of questions. This is get to know, but we started late, so I'm going to make this quick. One thing, what do you hope to get out of this training? Just one, I'll take one.
We hope that by the end of this training, you will be able to conduct cognitive behavioral therapy for most of our patients. Okay. Add something to what we have already been doing. Okay. Yeah.
All right. Put it all the way down. Workshop today, I'm thinking, I'm going to just highlight some basic CBT principles, and it sounds like most people or some people in here have that down, which is good. To understand the cognitive model of depression, to use CBT strategies in your everyday interactions with people, to help you engage and work more effectively with your patients, to give you a new way to make a difference in your patients' lives, and also to reduce burnout and bring more vitality to your work. That is my hope. And that's our agenda for today. I won't go over the whole thing. We can move on to the next one. Jonah wants to make copies. So when it comes to CBT, it's goal-oriented, so a lot of times at the onset of treatment, we want to be talking to patients about what is your goal, and we break those goals down into little steps. What's your short-term goal, what's your intermediate goal, and what's your long-term goal. And all those things have to be connected. And one of the things that I notice oftentimes I'll talk about my staff, they're not here, but sometimes they forget to, they'll get caught up in doing interventions for patients. They forget to tie those interventions to their goals. that's always at the forefront of my head because everything I do, every interaction, it has to be tied into their goal. So, it's focused on the here and now. A lot of times people think that because CBT is focused on the here and now, we don't take into account history, but we do in fact take into account. Target the thought because what we're trying to do is with a cognitive shift is going to lead to a change in behavior. When we just change the behavior, it usually don't revert to the cognitive shift. So we want to focus really on the thought. All right, moving on. And as you guys know, it's really tailored for the individual and their specific problem. So you want to narrow it down and make it very specific to what they're going through. The goal of CBT really is to help a patient recognize their negative patterns of thoughts. Yes, and evaluate their validity. So how valid is this thought that you're having? Is it bringing you closer to your goal? Is it bringing you, taking you away? And then you want to replace those negative thoughts, like you said, with healthier ways of thinking. So that's really what that's about. Do we have any questions so far, or can I move on? I'm going to talk a little bit about the cognitive model. I'm going to relate it to real life. Before we even get to that example, in the morning, I know in the States, people use alarms. So when the alarm go off, is usually my example. I said, when the alarm go off, what's the first thought that comes to your head? What do you think? How do you, how do you feel? And then what do you do? So for a year, when you wake up in the morning, what's the first thought? Anybody that comes to your mind? When you hear the rooster crow, when you're like, oh God, I gotta get up, what happens there?
You go to the bathroom, take your bath, and you shouldn't think about breakfast because I think we have here a good time that we wake up, so you have to get ready and come here early. Yes.
So wake up for work. I mean, do you wake up like, yes, I have to get ready to get up for work, or do you wake up like, oh my God, I have to get ready? And so when you have that thought, how do you feel?
Especially when I wake up, like coming here to work on Saturday, I always complain. I don't like this Saturday schedule, so I can feel bad.
Behave in the morning on your way to work or when you get home. It's true. And I'll go a little bit more into it, but I use the example here. For me, I have appointments. If I have an appointment with a patient and they don't show up, depending on my relationship with that patient, if I think, oh my goodness, I can't believe another blown appointment, the next time I see them, I won't be too happy. If I see them in that day, maybe later on I'll be fine. But if it's a patient that I have good rapport with and they have a good track record of coming, I may say, oh, you know what, something might be wrong with them today. And I'll call them, are you okay? And so my behavior will be a little bit different. So the idea is that the way that we think affects the way we feel, then affects the way that we behave. So that's just the basic CBT principle. We can try it, which I just went over. How we think affects the way we feel and the way we behave. I use another example. You can skip. Sometimes when I work with, patients with schizophrenia, they can be challenging, especially the ones with what we call the ones that have predominantly negative symptoms. Those are the ones that they don't want to take care of they don't want to get out of bed, they don't want to shower, they don't want to do anything. So I go and talk to them and they refuse to talk to me. I can be like, oh my goodness, this person is such a pain, which leads me to be frustrated, and I may even not want to talk to them in return. Or I could have the thought, this patient must be having a really rough day. And that evokes some compassion within me, and I might be a little bit more curious to find out, is there anything we can do to get you out of bed today? Again, same process, just a different model. I'm visual, so you'll see some visual things on there. All right, so that's that. Are we following so far? Yeah. Okay. Cognitive model, basically, we talked about beliefs, which are basically the thoughts on the CBT component. That's the cognition piece. And we break them down into three elements: automatic thoughts, intermediate beliefs, and core beliefs. So for some reason in my head, I was like, oh, I came up with this tree idea. And I realized I was talking to Dr. Beck. He is the father of cognitive behavioral therapy. And I collaborated with him on my pilot program. And he said, well, you must have read that someplace, but I would like to take credit for it, but it's not me. But the core beliefs are basically, all right, let's start from the automatic thoughts. Automatic thoughts is usually the first thing that comes to your mind in a situation. The thought, and it's quick, some people, for me, I think in images, that's why I say I'm very visual, and some people think in words. So it may be a thought or it may be an image. And intermediate beliefs are basically just rules that, like, oh, if I let my guard down, then people will take advantage of me. So they're kind of like that, the trunk part of the tree. Automatic thoughts are like the leaves, more they're more accessible to conscious awareness. And then the core beliefs are just deeply held, kind of rigid beliefs that we've had for so long that sometimes it takes a lot of work to even get to those beliefs. And we'll talk a little bit more about them, so that's just a quick overview. All right. Let me keep in mind time. Again, automatic thoughts, as I mentioned, is the most superficial level of cognition. It's closest to consciousness from place to place, from event to event. I may have an automatic thought like, oh my goodness, something's wrong with me. Do I have something on my face? And another instance, if I'm with a friend and Alan is looking at me, I'm like, do you like my eyes? It might, it's an automatic thought. It might be different from situation to situation. So, like I said before, you're barely aware of the thoughts. You're more aware of the emotions. So I usually tell people when you can think I ask people if I want to elicit an automatic thought, I say, what just went through your mind? I don't ask, what did you just think about? Because again, the reason why I say what just went through your mind is because we think in both images and we think in both thoughts. So when I tell people, what are you thinking about? Sometimes they look at me like, what do you mean? But when I say what just went through your mind, they go, oh, I saw this, or I thought about that. So it's just a little thing that I find to be effective. Intermediate beliefs, we went over that, so we don't have to spend too much time on it. Keep it in mind. Core beliefs, again, is usually fundamental. It drives who we are. It really drives how we behave, how we interact with others. And it's something that developed from our childhood. So it is influenced by, our family, our friends, and just other messages that we've gotten growing up. And that's really what forms that basic belief system that we hold. And I wrote there that it can be activated based on the situation. So when you think about those things together, I'll tie it together here. For example, I use this. You're in a crowded room and you notice someone staring at you. Your automatic thought might be, everyone's staring at me. Your intermediate belief might be, if they're staring at me, there must be something wrong with me. And then your core belief is, I'm defective. So does that make sense? Like there's something wrong with me at my core, something must be wrong. Again, people usually can't grasp the core belief part because it's so deeply rooted, but it's just an example. It can be multiple core beliefs. All of us here are walking around with different core beliefs that kind of drives our behaviors. Yes?
Where the person is saying I'm defective. But is it also possible that one could have the thought that, well, I think something good is about me, this is what people are staring at me?
Yep. A core belief is on core belief or intermediate belief. So yes. When and up there is oftentimes our patients, they're thinking, they're having negative thoughts. They're not having positive thoughts, or else they wouldn't be so depressed. They're feeling like I'm crap, I'm worthless. So that's why that's in there. A lot of us here, really, when did I do that? Whoa, we're getting fancy. Okay, a lot of us here have basic training in, I think, right, in DSM diagnosis. I included those there just because for your own information, but I won't spend too much time going through all the criteria for depression and what that looks like, because I really want us to focus more on what's the cognitive model of depression and what are things that we do in terms of intervention for that population. So generally speaking, when we think of depression, these are some of the things that come to our mind. Guilt, worthlessness, hopelessness, feeling empty or sad, fatigue, lack of energy, insomnia, hypersomnia, those kinds of things. I thought it was interesting that Jonah asked me to talk on depression because in my research I saw that Johnson was a doctor here and her colleagues did a study looking at post-conflict Liberia and the mental health situation, and that 40% of our population met criteria for a major depressive disorder. I thought that was a significant number because that's really, really high compared to the norms that we see. So hopefully this training today will be effective for you in some way in terms of helping not just our patients but one another. Okay. So that's just the diagnostic criteria. Again, I included it for more of your reading at a later time if you wanted to go over it. But if you have any questions about it, please feel free to ask me. Let's see. All right, moving on. How are we doing with time? Oh my. Okay. Oh, really? All right. I'm trying to be considerate of people's time, so am I going too fast? Okay. All right, so, So now let's talk a little bit about the cognitive theory of depression. I use Beck's model of depression because, again, that's who he's the father of CBT, and that's who I have a partnership with. So that's why I use him. But basically, his theory of depression is threefold. One, it talks about the cognitive triad, which I'll go over, and it also has a piece about beliefs, which we've talked a little bit about already. And then it also talks about the information processing difficulty that patients with depression face. So we'll talk about those as well. The cognitive theory of depression, the cognitive triad, it basically says that depressed people have unrealistically negative ways of thinking about themselves, about the future, and about the world. And when I say the world, I'm including people in the world. Okay? And I want to stress something here. In talking about all these different elements, like the cognitive triad, it doesn't really have to be stuck to psychopathology or mental illness per se, because we all have those thoughts. We all have ways that we think about ourselves, about the future, and about the world. But with depressed people, I think it's to the extreme. It's the extent to which they do it that make it a little bit more problematic for them. So I give an example of one of my patients who's depressed. The way that he thinks about himself is, I'm a bad person. Future, things will never get better. The world is just unfair, because all the things that's happened to me that led me to this point that I am now, I think his thought is that I'm being punished somehow. All right. This is the part that gets at beliefs. I talked a little bit about this, and I said our belief system is formed over time from messages that we've got from our loved ones, our parents, our teachers, and people that we care about. And it really shapes the way we think, which obviously then shapes the way that we behave. So some of the assumptions that we may be walking around with is, I gotta get everybody's approval. Or, I have to do things perfectly. If I can't do it right, I'm not even gonna try it at all. I see that a lot with patients that are depressed. It's like, if I'm not gonna do this, I'm not just gonna do it. I'm just gonna stay in bed, I don't care. And also, I must be valued by other people, or else I'm like, my life is meaningless. They put a lot of emphasis on people catering to them, or people valuing them in some way. And I actually see it in normal people as well. So, it's not just specific to the depressed population. I already mentioned that. It's not so much unusual, but depressed people just hold on to it so much more strongly. Cognitive theory of depression. So this is the third fold of this. Information processing. Depressed people are usually prone to misinterpret information from the outside world, okay? So by that I mean, say for example, somebody was supposed to call them and they didn't call them, or somebody was supposed to visit and they didn't visit. We might say, oh, maybe their car broke down, or maybe something happened to them. They'll internalize it and personalize it and say, oh, it's something that, they just hate me, they've always hated me, it must be something about me. Again, it's the thinking, so much more negative than we would ordinarily think. And they tend to make, overly negative or self-defeating interpretations that lead them to feel even more depressed. So if you're saying that I'm horrible and this person just don't like me, you're not going to feel happy. You're just going to put yourself in a more depressed state. Okay? I included here cognitive distortions or misinterpretations in depressed people that are common. And I'm going to leave it up to you whether or not you want me to review it, or do you think we should kind of skim over? What do you think? The first is arbitrary inferences. Basically, it's when they draw a negative conclusion based on like a small information. You know, like the example that I gave today, right now, may be a little something about that. So, for example, I don't know, you know, Alice, again, look at me. Oh my goodness, the whole world don't like me. She really don't like me because of the way that she just stared at me. You know what I mean? Again, it's one little information, but I've already blown it up into something bigger than it is. It's very much closely related to overgeneralization, which I'll get down to. Selective thinking. People with depression tend to focus so much more on the negative, and you can't draw, or it's really hard to draw something positive from them. A lot of times when I sit and I try to do an assessment with someone that's depressed, and I'll say, you know, what are some of your weaknesses? They can give it to me like that. But when I say, what are some of your strengths, or what are some of your coping skills, we sit in silence, you know, because they can't think of any. So now it's up to the clinician to think about, well, you know, you did graduate high school, you managed to bring yourself here to that, you know, in your pool, and you have to kind of be that, you know, that process for them until they can get themselves there. So that's selective thinking. The other piece is overgeneralization, which, you know, you just draw a conclusion based on one single thing. Okay. Can anyone think of an example of overgeneralization where somebody take one instance and they blow it up into something bigger? Yeah.
They have certain trial and they will say, because one person did so things, so they will say the whole trial, like they try
Stereotype.
stupid. You know?
Yeah.
Okay, because one person did it, so the judge conclude about the whole trial.
Yep. That's a book for the whole tree. That's that. The other thing is catastrophizing. It's just over exaggerating minor setback. For example, say so you went for a job interview and you didn't get this job interview. The thought, if I'm depressed, I might think to myself, I would never get a job anywhere for the rest of my life. That's catastrophizing, you know what I mean? It's one simple incident, but it's now caused damage to my entire life and my entire future. Personalization. Taking responsibility or blame for unpleasant things that happen. It's interesting because with people with depression, they don't take blame for positive things that happen. It's usually the negative things. So maybe my child is sick. Oh, you know, my child is sick. I'm at fault. You know, it's because I was a horrible mom. I didn't give her this medication this day, or I didn't go to see her. Again, it's personal. And sometimes you may find people who might take it to the extreme, and this borders a little bit more delusion on personalization. For example, maybe it rained and it won't stop raining. Oh, I'm the reason why it's raining today, and everybody's day is ruined. My day is ruined because it rained. It's because of me. Just so it's a little bit on the psychosis end. Black and white thinking. It's usually all or nothing. It's either I'm all good, I'm all bad, this is going well for me, or it's not going well for me at all. They can't see the gray area. So those are just the basic, the most common cognitive distortions or misinterpretations that we see with patients with depression. Do you see some of that in your work? Like sometimes when I talk about things, I can picture certain patients that remind me of that particular piece. So, okay. Can you go back, Kim, for a second? So I talked to you about just basic CBT stuff. I included the depression diagnosis. We talked about the cognitive model being threefold, the cognitive triad, our thoughts and beliefs, which I have in there as silent assumptions, and then information processing difficulties with patients with depression. All right. Do you guys have any questions so far? A little bit. We're getting to the nitty-gritty. So interventions for patients with depression. Before we even get to do any kind of interventions whatsoever for patients with depression, there are certain fundamental things that we need to keep in mind. So I included two of them here. The one being a case conceptualization. A lot of people fail to do this. I think it's so important. And so we'll talk a little bit about it. And the other thing I included was basically communication stuff, and we'll get into that a little bit. So for case conceptualization, when I sit with my staff and we have a multidisciplinary supervision or consultation, this is the first place that we start. Pick a patient, we go over their history. I want to know everything about their environment, their families, their upbringing. I want to know about their belief system. What's kind of driving them right now. Compensatory strategies are basically Maladaptive behavior, so things that are not so good for the patient that they engage in. For example, with a depressed patient, a compensatory strategy might be not bathing for one whole week. They're choosing not to bathe, or for other reasons they're not bathing. But it's not helpful and it's not healthy. Coping skills are more positive things that patients do to kind of bring them closer to recovery and bring them closer to meeting their goals. So, and we'll a little bit more about this. So when I talk about the core ingredients in that history part. Genetic predisposition and temperament. So again, family history, family mental health history. I want to know about your temperament. Are you somebody that gets vexed fast? Are you someone that cries easily? What kinds of things trigger you? I want to know about invalidating family environment. A lot of my patients have history of sexual, physical, and emotional abuse. All three. It's rare that I find none, or it's rare that I find one. And oftentimes, with some people, maybe they only were raised by a grandparent, or maybe one person, maybe a mom and not a mom and a dad. So we'll have those kinds of things. Also, poverty is a component as well that I take into account. Do we need a chair? I think about drug use as well as cultural norms. Can we? Back. One more back. All right, and then we talk about this unmet childhood needs. I won't go over every single one of them, but you can take a look at them, and if you have questions about them, let me know. One of the biggest things here that I see a lot of times, unrealistic expectations come up a lot for me with my population. Their parents may have been like, okay, maybe their parent was a doctor or something, and they expect this child now to be a doctor, but the child don't want to be a doctor. They're not called out to be a doctor, but it's imposed on them. So a lot of times they feel like I can't cut it, and it might make them feel even more depressed. So that's a piece that I see a lot of times also. Abuse, we talked about that component, that's usually huge. And then parents not modeling autonomy. For example, a lot of times, there's a huge comorbidity in terms of, or association between patients that are depressed. They also have a family member or a parent that's depressed, or a sibling that's depressed. And we get into the diciness of whether it's more a genetic component, or if it's just the nature of the environment that they are being raised in. It's a combination of both. We can't tease it out all the time. So that's that. The other piece is lack of protective factors. Again, no healthy role model in their lives, okay? Inadequate peer support, lack of medical care, which here is a huge piece here, especially with you guys being the only mental health facility in the entire country. That's tough. A lot of times people, your relapse might be due to the fact that medication regimen, you know what I mean? Or there's no community support to do that. So they end up not taking their medication, ending up back here again and again and again. So that's a huge piece, I think, for this place. There's a high comorbidity there. So if they're not caring for their medical state, they're not caring for their mental state. It's kind of interrelated. And lack of therapeutic interventions. Again, that's you guys. I think you can relate to that in Liberia here. All right. So that's that. The belief component, I wanted us to kind of generate some beliefs for ourselves instead of me doing all the talking. So we talked about beliefs. Can anyone tell me a little, what are the three kind of beliefs that we've reviewed so far? Yep. So if we say an automatic thought that a depressed patient might have, we did an example earlier, but can anyone come up with another example? Things that come out of their mouth, the words that come out of their mouths.
Yeah, for somebody substance user here, they will say they smoke, you gotta see their friend smoking.
Okay.
Yeah.
Sorry. So what do you think? Yep, so that could be automatic thought. I did it because, my friends do it. What might be an intermediate belief on that same line? If blank, then blank. Someone wants to help in the process?
They smoke because when they're smoking, you can make them smart.
Okay. So if I smoke, then I'll be smart?
Yes.
That's an interesting, this is the tough one. What might be driving that if then, if I do this, then that? How do you think they feel about themselves, or about the world, or about other people?
By the fact that they think that nobody loves them.
So I'm unlovable. Yep.
Be that they are the bad ones.
Yep.
And they blame other people. And they say no better future for them.
Exactly. So those are all real beliefs. People don't get it, but you guys get it. So is that really rigid belief that's kind of driving their system? So you hit it on the head. Thank you. All right. So moving on. I talked a little bit about compensatory strategies earlier. I just go into a little bit more details here. Basically it's behavior that people engage in to either prove or disprove, their core intermediate belief. For example, if one of the core beliefs that was given was, there's no, I'm unlovable or something, you might find somebody just be straight nasty. They might just be mean just because, it feeds into the fact that I'm unlovable. Does that make sense? Okay. I give an example here, if they feel like there's no point of doing anything, they may just stay in bed all day, or they may just not shower. I don't care. Why should I even try? So again, those are compensatory behaviors, and they kind of get in the way of them being able to recover. So you guys, your job here is to work with those compensatory strategies, coping skills for the compensatory behaviors. Does that make sense? They're basically things that people do to improve their symptoms, okay? And it can be a strength, and it's something that brings you closer to recovery, brings you closer to your goal. Can you think of an example of a coping skill?
Breast patients under conducting circle education, pretend to get involved in activity. They go to focus group, to discuss with people. So I think it's a form of coping skill.
Yep, those are healthy coping skills.
Neighbors, the relatives of mental health patients, we tell them to count on their efforts that they have applied in bringing their patients. They should find time to read, to listen to music, to go to places that they love, so that they can now continue to be stressed out because they have a mentally ill patient.
And we can use givers. We give, and we forget to take our own advice. I'm speaking for me. We forget to take our own advice. So I'm quick to tell, families, oh, you know what, listen to some music, go to the movies, hang out with friends, and whereby we may be giving so much to our patient and not replenishing ourselves. So thank you for that example. We all need to practice it in this room. Was there any other coping skills?
Instead of telling them what to do, you ask them what they like doing. Because what he said, that music or nothing, you ask them whether they're in a women group or a football team so that they can do more of it every time they think about what bothering them.
Yep, exactly. So it's good. We'll get into that. Communication skills. That's the next piece. So I talked about fundamentals, right? The first fundamental is understanding that the case conceptualization, having a full picture of the patient before you go in trying to move in and do an intervention. The other piece is being able to communicate with your patient effectively in a way that's going to be helpful for them, not in a way that, makes you feel good as the provider. It's about the patient and it's about your collaborative work together, not just about us, okay? So I'm gonna cover these basic things. Recovery-oriented language, using language that's helpful and not hurtful for the patient. Empathy, validation, guiding versus telling. That's where I said, you got ahead of yourself, like asking them, what are some of their coping skills? What's helped in this situation before? And then also, a process that I call SCEP it stands for summarize, check, empathize, and proceed. So you guys will get to practice some SCEPing with each other in a little bit. So we'll move on. All right, so that recovery-oriented language. Basically, in my field, when patients are depressed, sometimes people say, oh, they're just being lazy, or they're just seeking attention, and not really understanding that it's a legitimate mental health condition. And these people aren't just choosing to be lazy or choosing to seek attention, but that they're actually struggling, you know what I mean? The thing is, when we think of someone as being lazy, think about that cognitive model that we talked about earlier. If your thought is that the person's being lazy, how are you going to feel towards them?
Sometimes you behave awful when you come around there.
Exactly. Exactly. But what kind of feelings are going to be evoked? How will you feel about them? Being more happy to help here.
Aware of how that patient is feeling, and you try to identify yourself as though you are the one that feeling that pain of that patient.
Right? Okay. So that again, it goes back to that basic cognitive triad that we were talking about. This is a struggle on my unit because they may say a patient. Again, I work with patients with psychosis, so they may say, "Oh, this person's being a pain in the butt." You know what I mean? So instead of being a pain in the butt, maybe we can say, you know what, they're really struggling today, or they're engaging in a behavior that's not so healthy. And in all honesty, yes, there are patients that are a pain in our butt, and it's true.
Constantly in the eye.
Oh yes. 100% teams here, but the good thing about working in teams, you can go to your team member and be like, oh my goodness, guess who I just met with? And they were a pain in my butt. You know what I mean? But obviously, you don't want to tell the patient you're a pain in my butt, because it's not healthy. But it's a reality of it. All right, so we can move on to the next thing because we covered that last piece. Empathy. So empathy, what is it? You guys have already talked about it. It's really being able to put yourself in the person's shoe and really feel what it is that they're feeling, understanding their emotional state. I had an instructor when I was being trained as a structural family therapist, and he said sometimes certain parents that are enmeshed, when it comes to empathy, they take empathy to the extreme. They literally, he says, they zip their skin and get inside of their child's skin, and that's a little bit too much empathy. But empathy is being able to put yourself in the person's shoe, but still having some differentiation so that you can help. Because when you're over-identifying with the person, you're now stuck in the same situation that they're in, and you're no help to them. Okay? Does that make sense? All right. So move on from empathy. All right, empathy, again, it's one of, so time and time again, research shows that it's a critical component in terms of forming a therapeutic alliance, so like a good relationship with your patient, and in terms of treatment success. So if you don't feel what the patient's going through, you're not able to effectively help them, so you just won't care. But if you actually can relate to their struggles, you're able to help them a lot more, and a lot more effectively. And so I think a lot of us can relate to that. Also, if you have empathy, you're able to form a better rapport with the person. You can talk to them a little bit more, and they feel like, you know what, this person knows where I'm coming from. They understand what I'm going through. So you can work with them that way as well. Again, lack of empathy is the single biggest.
I want to say something about empathy. I remember once upon a time, I was in a screening room. This lady came in. Physical appearance was very, very sad. So she came, I told her to have seat. I introduced myself to her who I was in that screening room. Then after everything, I said, Madam, what is your name? And she called her name. And I did the other page. I said, what made you to come to this mental health and hospital? What is happening to you? The first thing the woman did was she started to cry. I said, what's going on? He said, yes. I got 5 children from my husband, because my husband was ill during the war right before me. I'm together going through it, nobody will help me. And number 2, the children are frustrating me, they are not serious. They're just in the street, drinking, smoking, here and there. Myself, I sat down for a long time. I put myself into her shoes too, because I got 5 children. My husband, as for me, he died from motor accident. So myself, I think otherwise I went closer to her. I started to
empathy.
After everything else,
everything was in action.
I talked to her, the problem that I passed through, even though my children are not a smoker nor a drunker person, but there is a little difference that was between our children and mom, the children. So for that reason, I did it as assess me. I tried to cancel hospital. The little time that was able to provide for her. I went for it myself in the speaking. Got it. I told her how to take it. We coming for counseling most of the time because that area that the people will talk with you about your condition. And she gave my number once in a while and called me. It's fun.
But that's, if you didn't even take the time to say what's wrong with you, you know what I mean? That's like the doorway to empathy, right? What's going on for you? That shows a little bit of care. Like I care. I'm concerned about what I see. I'm concerned that you look sad. And if you didn't do that, you wouldn't have been even able to understand that you guys have similar situations and that you can relate to some of the things that she's going through. So that is a perfect example of empathy. Yeah.
In your situation to a patient, because you know patient have that world view that you are the master of their problem. When they come to you, then you explain similar situation. Is it right?
I think that depending on the school of thought that you're coming from, it varies, okay? I say use your clinical judgment. There are certain things that you can share with patients, maybe things that I would find as that's not going to be too harmful for the therapeutic relationship, or that's not going to make them think of you as less than capable of caring for them. You know, for example, you can say, I can relate to that. That must be really hard for you, and maybe give an example that's a little less than, I went through the same exact thing, and I'm going through it right exactly now. It really depends. I don't like to tell people how to go about conducting their therapy, but I think go with what feels right for your own personal style. But definitely keep in mind that too much disclosure can hinder the therapeutic alliance. It can alter the relationship a little bit. So kind of do what you feel like, use your clinical judgment. And we all have that little voice in our head like, maybe I shouldn't share that, but I can share this, But that's a debate that's going to be going on forever and ever and ever. Yeah.
Just in the field that I'm in, I try not to be the best friend. You don't want to be the best friend because you don't want them to be dumping everything on you and expecting you to do a quick fix in solving the problem. So by telling all your business to them, now they have that hole and the two of you are like this. Right. Exactly. But you don't want to be their best friend.
Yes.
Okay. Setting people, like, of course you're taking care of them, but don't make them feel like you don't have other problems, because they don't think everything is okay in their eyes. But you have to kind of for you to get information from them. That's the only way you can get their information. Then you use that, to get that information. Some people, that's the only way you can reach them. If you don't do that, you will never reach them.
When you're working, sometimes
it depends on you.
Yeah, it's so true. Sometimes you do need to give a little bit to get a little from patients. But again, it's a delicate balance. You have to be aware of your own psychodynamically, I will say countertransferences and transferences. But we're doing cognitive therapy, or you have to be aware of your own thoughts and how those thoughts are going to impact that relationship. You know what I mean? So it's a dance that we can dance. But that's a great question that you brought up. All right, you show empathy by saying, asking how questions and what questions, not so much why. Because sometimes you say, well, why are you crying, or why are you doing this, or why are you mad? Some people might be okay with it, but sometimes even I have put my foot in the mouth by saying why, and they're like, what do you mean why? Because some people might take that a bit as you being challenging or coming down hard on them. But if you say, how did this happen, or what led you to be this way, or whatever, they see that as more inviting, like you really want to know. So again, it's a linguistic issue, it's language. It's the language that you use that's going to elicit certain kinds of behaviors or certain responses. If you don't want the person to be defensive, please avoid saying why. But if you want them to be defensive, then go for it. Say why all you want. All right, so that's just that piece right there. Empathy is a big thing for me, clearly, by all the slides I have. You can express empathy both verbally and non-verbally. Like Mom, I forgot your name. So Mrs. Fumo, right? Mrs. Fumo said, I drew know, and I care, you know, your tone of voice. If someone's sad, you don't want to be sitting over there screaming, but what are you crying for? You know, it's kind of like, seriously, you're not meeting me where I'm at right now, you know, so it's just, but, you know, if they're crying, you want to have a gentler tone of voice, and you want to be calmer, and you want to be comforting. You know, facial expression, like give them eye contact, you know. Certain people may interpret eye contact as being a challenge, so you want to gauge it. You may give a little bit of eye contact, look away, but still be in the area that they're in, you know what I mean? I was just interviewing some postdoc students, and one of the things I looked at, I take them to the unit and I have them talk to my patients. And if I have a patient sitting down, I don't want you standing over top of my patient talking to them. It's not okay with me. I don't do it. I lead by example. So if my patient's sitting on the floor, guess where I'm sitting? Right on the floor with them. You know, if they're exercising, guess where I am? Right in that exercise room with them. Again, it's creating a synergy. It's creating a nice, letting them know, you know what, I'm no better than you. I'm right where you are, and we're in this together. So those are all non-verbal expressions of empathy. And we talked a lot about the verbal piece, you know, you must be really frustrated, whatever. Validation. I include this because it's a little bit different from empathy. A lot of times people think they use them interchangeably. They're closely related, but they're not the same. Validation, I like to say that empathy gets at the emotional component, validation gets at the cognitive piece. Like, I understand why you would be feeling this way based on everything that happened. So really it says acknowledging the patient's current behavior makes sense because of their, you know, past or even current situations. Validation, if you make someone feel validated, like instead of saying you don't have no reason to be crying, other people got worse situations than you, saying, you know what, I understand why you would be sad because you just lost your husband or you just lost your child or whatever, and you know you're a single mom, whatever. It gives them the room to want to say more. You know, but if you say you don't have no reason to be crying, I myself, disclosure, I lost, you know, 7 children, and then, you know, it's invalidating, and then it makes them shut down. They'll just look at you like, you know what, I don't even want to talk. Validation. And the reason why I included here is the piece about, a lot of times, I know with my patients, a lot of them grew up with people constantly invalidating them, telling them, oh, you shouldn't cry, oh, shut up, you shouldn't be like this, you shouldn't be like that. For once, you can have the opportunity to be that person that model what validation looks like for them. And so that's why I think it's such a basic piece to any intervention. It's like a prerequisite, being able to empathize and being able to validate. Okay, so we can move on. And this is just an example of validation. You know, it's understandable that you want to stay in bed all day, given that that no one has taught you any other way to handle your emotion. That's validation. You can use tons of other examples. So I'm gonna now ask you guys for examples. I need at least one example of how would you give a validating statement to someone.
A young man's sister was being raped, and he decided to stop the person that raped his sister. You can validate that the person has the right to get angry because the sister was being raped. But to take a knife to stop that person will also not be the right way because he will be coming against the law. So you acknowledge the fact that he's annoyed because the sister was being raped, but you try to also make him to realize that stopping him is like taking the law into your own hands.
That's a beautiful example for 2 reasons. I would say it gets at the maladaptive behavior. So stabbing the person is a maladaptive behavior. You know, being mad it's adaptive in a way because it's normal. We would all be mad because, you know, our sister was raped. So I really like that. You know, and oftentimes people say, oh, so should we say, oh yeah, you know, it's good that you were mad and it's good that you stabbed that person. Validation all around? No, that's not it. But I like that you were able to dissect. See that? No. So it's good that you were able to dissect. This is the piece that needs to be validated, the emotional piece. But the maladaptive behavior component, I can't validate that. You know, it's wrong because it is against the law, blah, blah, blah. Perfect example, thank you so much, versus telling. Guiding is kind of like a self-discovery in that you're asking the patient's questions. You know, do you remember what helped you when you were feeling sad? Can you remember the last time, what did you do when you were like this? You know, it's not telling them what to do. It's not, you know what, when you feel sad, you should just go shower, you know, or you should just go walk, you know, because when it's not coming from the person, it doesn't have the same impact. But when they self-generate it goes much further. I noticed that with clinicians, this is really, really hard to do. And maybe it's just my clinicians that is really hard to do because most of us, we want to help. When we tell, it's not coming from a place where it's like, oh, I know what's best for you. Sometimes it's coming from a good place. Sometimes it's because you're so desperate to help the person. But telling, again, it portrays you as, oh, I know it all and I'm the expert and you don't know what's best for you. We want to go against that grain. We want the patient to know that they know what's best for them and they can generate, with our help, their own problem. So that's why we guide them to their own solution. All right? So do we get the difference between guiding and telling? Yeah. Floating ideas, what I would call floating ideas. One technique when we use guiding is to float ideas. As I said, guiding is just a gentle way of suggesting alternatives. You know, you can say, well, if the person can't come up with anything at all, you can say, I wonder if it would be helpful for this. Exactly. Or have you ever thought about this? Again, you're not telling them, you're kind of just floating it and giving it to them. They can choose to say yes or no. So that's the whole idea about, floating ideas. Obviously, you use it with empathy. If you haven't tried any empathy, don't go floating ideas to people because they're just going to look at you like you're crazy. So, empathize first and then float an idea. Okay? Basically, guiding really increases your collaboration and working with people. Alright? That's just that piece. We can move on. Examples of floating ideas. Alright. I always say, again, I can deal with, my patients with schizophrenia, I can deal with the positive symptoms. I can deal with them talking about all the different things. But it's the patients with negative symptoms that are more difficult and more challenging because I have all this energy and they have zero energy. And we're trying to find a balance between both of us. So, exactly. So, oftentimes I'll say, or with patients that are depressed, again, they present a little bit similar to the negative symptoms folks. You can say, sometimes people I've worked with have found it helpful to walk with a friend. Do you want us to take a walk together? Let's just get up out of the bed and walk around the room. So that's an example of floating an idea. And again, they can say, no, I don't want to do it. Yes, I want to do it, or whatever. I wonder if there's another way to look at the situation. A lot of times, people that are depressed, we talked about them only looking at the negative. We can float an idea by saying, well, I wonder if there's another way to look at it. And then you can generate alternative solutions and they can, again, pick or choose what works for them. Okay? All right, we're going to practice. How many people do we have in this room? I'm tired of talking. So everyone find a partner, please. And we are going to practice guiding. So floating an idea as opposed to telling the person. So just for 2 to 3 minutes. So and the scenario basically if you read is you have a depressed patient that they don't want to get for me, our patients stay on the unit, so usually they don't want to get out of bed. But your patients come to you. Pretend they don't want to get out of bed and you're trying to find an alternative to get them out of bed. So guide away, and I'm going to walk around and see how it's working. Who's the patient? Who's the therapist? Are we? Who's the patient? Who's the therapist? Who's the patient? Oh, you got too much emotion for a patient. It needs to be exactly. So you're a depressed patient. Here's our therapist. So how are you going to guide her? Say you're trying to get out of bed, she's in there, or you're trying to get her to do something.
Maybe. Wow, you staying, man.
You don't want to get out of bed?
Necessity, you can tell me why you don't want to get out of bed?
Not today.
No.
Okay, let's burn it. So what? So full some ideas to her.
This patient is tough.
She's tough, but that's usually how, patients with depression show. You guys are lucky you don't have to get them out of bed. They actually come to you. Well, some people are inpatient, right? So you have to get them out of bed here. So, all right, so what would you then say? So I may say something like, when was the last time you got out of bed?
When was the last time you got out of bed?
And when you got out of bed, how did you feel?
When you got out of bed, how did you feel? Same. When you say the same, what do you mean? Say that?
Just how I feel, I'm lying.
She's tough, but this is a good patient. This is a good patient. So you may say something like
Because if you would just lift up the head so we can talk a little bit. I know you're tired. Just try to lift up your head so we can talk a little bit.
this is a success. So again, all right. I want to stress something because a lot of times, when we do therapy, right, we want to look at the larger things, like, oh, I got out of bed. But the simple fact that you were able to get her head from being laid on the couch to actually lifting her head, that's a success. And we will take that and we will say, yes, you did a good thing today. And then, in CBT, we always want to get at the thought. So I may ask her, after talking to her for a little bit, well, how did it feel that you had your head up? Do you notice you had your head up for 5 minutes, Oh yeah, I noticed. Well, do you notice the difference when your head was down on the floor or when you were sitting up? So I may want to get at the cognition. And oftentimes you have to do a lot of pulling, but they can eventually say, you know what? I enjoyed talking to you, or it was okay. We'll take it was okay, then it was horrible. Again, it's the little successes that we wanna stress on. Okay? How did it work out for you guys?
Well, I spoke to my patient. I saw how she was feeling this morning. She did not say anything.
She didn't look at you. She didn't look at you.
She didn't say anything, so I said, but you are not saying anything. How are you really feeling this morning? So she said, the same. So I said, what did you do yesterday? She said, I was lying down. And I said, well, you feel like doing anything this morning? She said, no. I said, they are showing a movie under the wall. Do you mind if we go there? She didn't say anything. I said, it's a fun movie. Have you seen this before? She said, maybe. So I said, will you mind if we take a walk there? And then she smiled at me. So
there we go. That was a success. So you smile. All right. Okay. Who else was the patient? Who was the therapist?
Was the patient.
Don't listen.
Okay. Okay.
I met her in bed and then I spoke to her. She didn't want to talk and I kept, I said, what's going wrong? And she told me she had got in a fight with somebody. So that one today she wanted to be all by herself. She didn't want to be bothered with people. So I said, you are not going to be going against the other people in the room, but can you talk with me? So she said she didn't want to be bothered. But I kept, asking, and then she told me, and the bitch can only give me 2 minutes.
Okay. So we got 2 minutes.
Yeah.
All right. Okay. Good. And did she actually talk for 2 minutes?
Yes.
All right. Good. All right. We starting now. All right. Go ahead. How did it go?
Okay, now I met with my patient and I greeted her. She was reluctant to respond, but after a while she was able to respond to my greeting. And I asked her what is the matter after this person. She stayed in bed. She said nothing. And I asked her as to whether she could get up for us to talk. She said first no. But after like 3 minutes, she decided to get up for us to talk. And I asked her as to whether she was waiting to do anything meaningful today, and she got annoyed. Whether that was the only thing that caused me to wake her up. So I tried to let her to know that it's not, since she spends most of her time in bed, it's sometimes good that she wakes up and be able to move around. So exercise, because exercise is also another beautiful thing that one could do to improve health. So
now, did you?
I asked first as to whether she will be willing to do anything.
Okay.
And she got vexed first. She said, "Is that what I woke her up for?" So
she was a tough patient.
Since I know that she's getting annoyed, I try to tell her the best thing to do is like walking around to do exercise.
So how can we? That's a good way to shift it. It's really just a language thing, right? And it's a great suggestion, but the goal is, I don't know why I do this when I say floating, and you guys are doing it with me. So we would say something like, or I could say sometimes, patients I've worked with find it helpful when they walk. I wonder if it would be a good idea for us to walk. So that's floating it to them. But good. Who was the patient? Who was the therapist?
He was the patient.
Okay. All right. Oh boy.
Okay. This patient is a patient at the E.S. Grant Mental Hospital.
Okay.
And at E.S. Grant Mental Hospital, we usually have activities during the middays. So everybody go on down there to take part in the activities. And when I came around, I met him sitting downside.
Okay.
So I asked him, "But what happened?" He said, "I'm just weak." Actually, he was not a very tough patient anyway.
Yeah.
Say, I'm just weak, and I'm just weak. So I asked him, I said, "But you said you are weak. What really happening?" He said, "You got pain in any part of your body?" I said, "No, I don't have pain in any part of my body, but I just don't feel going today, so I just feel that I'm weak." So I said, "But they have some other activity, video show, and other people are beating drum. How do you think about you watching video show today?" He said, "But what type of show are they showing?" I said, "Well, people they're showing a show where they got some stars, movie stars are dancing, and so y'all like to have movie stars."
All right. So success. We'll take that. Did you guys go? Patient staff, what happened?
I'm a patient for him.
He gave up? Oh, he gave up. You gave up? Oh, you can't give up as a clinician. Let's try this. Okay. So,
I did not give up.
Okay.
Okay. It's a Friday morning. I met my patient in bed. And it was an entertaining day. So I went to my patient and I tried waking her up, but she never wanted to be bothered. So again, I asked her, I said, "Today is Friday. What we normally do on Friday?" She said, "Really, I don't want to talk about Friday." And I told her, I said, "But Friday has always been an interesting day to you." So she said, "And so?" I said, "Yeah, but don't you want to look at this Friday, like the last time?" So I asked her to tell me how she felt the last Friday when that day came. And she started to explain. And I told her her active part, how she felt about it, and then she was able to explain her role that she played the last Friday. And I said, "But now this is Friday. So don't you think it would be best if you get out there to associate yourself with others?"
Yeah.
She looked at it and said, "I could give it a try."
Okay.
So I said, "But if you give it a try, then you let me know the feeling afterwards." So she decided to take part in it.
Good. You know what? I like this because you added a piece that I usually tell people to add, which is that actually engage in this, because you want them to remember the difference between before and after and draw that conclusion. You did it on Friday, I felt better. So I like that. Did you guys go?